Okay, now that we've heard from all of our panelists, I think we have a pretty good understanding of the landscape for our discussion. Before we jump in, I wanted to remind us of a couple of different things. First of all, Tennessee continues to rank in the bottom 10 in the country, 10 states in the country with regards to overall health outcomes. And this is according to America's Health Rankings. Currently, we rank number 44 overall. And that's not good. That means that there are 6 other states below us. We do have a decent, I would say, a robust public health infrastructure. We do have a local health department in all of our 95 counties, working with the Tennessee Department for Health for several years. I understand their priorities with addressing obesity, physical activity, tobacco use, which are the drivers for morbidity and mortality and increased healthcare costs. And there continues to be a voice to advocate for investment with regards to public health, the infrastructure to make sure that we mitigate those downstream costs. So I have 2 questions for our panelists. The first question, what role, and I'm asking you to answer from your perspectives of your subject matter expertise, what role does strengthening our public health infrastructure play in improving and lowering healthcare costs in Tennessee? And just a reminder, with regards to COVID, we know that there are public health messages that we hear every day. Those similar public health messages have occurred in previous years and continuously do occur. We just don't hear it because it's not national news. We're not in a pandemic. But those public health messages with regards to drivers of healthcare costs are there. So from your perspectives, how do we think about the public health infrastructure in improving health and lowering healthcare costs in Tennessee? And I'll start with Dr. Cahill.
Thank you so much, Tanae, for the question, and thank you to all my panelists for their very informative presentations. So I think I'm a public health person, so I come at this from a public health perspective. And what I would tell you is that an investment of just $10 per capita in public health can lead to a 1.5% reduction in premature death. And so that's investments in things like smoking cessation programs, help with obesity, help with women who are experiencing pregnancy. And the state has shown a willingness to utilize those kinds of policies in order to improve public health. And I think that might be something for this particular campaign to consider, is to try and pull some of those public health levers and investments to keep people out of the hospital sort of acute care settings as much as possible, by making sure they're as healthy as long as possible. Now, that won't solve all of the issues, obviously. It won't address necessarily the hospital issue in Scott County or some of the rural health infrastructure or some of the other issues the state has. But I think that's a really important step, is to think about what the state has shown a willingness to do, which is to do these sort of investments, incentives, in positive health behaviors, and ending negative health behaviors, and realizing that just a $10 investment can lead to a 1.5% reduction in premature death, which I think is a huge return on such a small investment.
Thank you, Dr. Cahill. Dr. Myers, I'm going to turn it over to you, and just sort of high level, same question, understanding how the Biden administration is thinking about this, and also traditionally, maybe, I don't know if you have any insight on how our legislators think about public health.
Sorry, I don't have specific insight on what the Biden administration wants to do around public health, other than they have telegraphed a willingness to look at that as part of the solution. And I want to build upon Dr. Cahill's comments. We focused on the cost of care and the fact, and Mayor Tibbles talked about people seeking care much later and our high rates of chronic disease in the state. Rather than just thinking about healthcare mitigating those things, we need to look further upstream, which is where public health swims around more than the clinical care system. So as Dr. Cahill has already said, much better return on investment, but it takes longer to get that return on investment. But I think it would be good for us to look at prevention and to look at those things that we know more than clinical care contribute to health, such as where people live, work, and play, their environment, their income status, their educational level. So I think if we want to take the long view, which is often very difficult in this political environment, that public health, the case is so strong and even stronger than the case for clinical care, which intervenes after the fact. So I think there's a willingness to look at public health because the investment is not as great. But I think one of the things that makes us stumble so often in our state and in the country is the long horizon for that return on investment. So we have, as we're going to have everything we talk about today, the yin and the yang. But I think we would be wise as advocates to consider public health as part of our overall strategy.
Thank you, Dr. Myers. And so, Ms. Beard, I'm wondering how we balance that long-term strategy that we need for that long game for public health with the urgent need right now for healthcare. If you could speak to that question.
Sure. So I definitely think that it's it's a long game and a short game. And so I think that the programs and products that the state, like Dr. Cahill said, already investing in, already showing good strides in, like the Tennessee Breast and Cervical Cancer Program that provides cancer screenings for women, caring for pregnant women, caring for newborns, our Vaccines for Children's program that makes sure that no child goes without immunizations regardless of their income or insurance status. But earlier Dr. Cahill spoke about the relationship between health and education, and much like Dr. Myers, I believe in an upstream approach. And so years ago, someone asked me what I thought was the most important piece of health, and I think the most important piece of health is education. And I think because education ties you to every way out, it ties you to your way out of poor health that you've been taught, because of your family or because of your community or your friends. Education is your way to better employment that potentially gives you access to healthcare or betters your income so that you can move to better communities. And so I think the upstream approach, and I know, coming from the healthcare position, I think the upstream approach is to make sure that we have quality education so that individuals can have access to quality jobs so that they can provide for themselves and their families, including access to childcare, including training for individuals to improve themselves daily, to improve their employment and employable opportunities. And so I think it's an and. I don't think it's an if or an or. I think it's an upstream and a right now approach.
Thank you. And Mayor Tibbles, I was wondering if you could answer how you think about or how your constituents think about the value of public health and balancing that with the real urgent need day to day with regards to healthcare access.
You're on mute.
Just trying to save that bandwidth. But when you talk about existing conditions and what will help, what programs the state has and the funding that they already have, but they're not using it in the right direction. If you look at the tobacco settlement, which is about to run out, I believe the tobacco settlement is around $24 to $26 million annually for the state. And this year, last year, I think they spent $500,000 on tobacco smoking cessation. Well, and it needs to be targeted. When we look at the distressed counties, that's where you've got 40% use of tobacco. It doesn't make any sense, in my mind, to target Williamson County, for example, who's probably got less than 5% tobacco use. It needs to be targeted in the right areas. And it not only needs to be used, not 500,000, the purpose and the money was not to balance a budget. It was put there to create programs that will get people to quit smoking and using tobacco. And when you look at, it's literally every other car that goes down the road here is they're smoking. So, and those numbers will prove that. I just think the state, in the last conversation I had, when I looked over and with our representatives, state representatives, and I looked at their budget year coming up, they are talking about increasing it, but have they said how much they're going to increase it? No, they have not. So it needs to be used, the full amount needs to be steered towards distressed counties. And I think that would want to be one of the biggest helps for health outcomes in Scott County. And I don't think I answered your question.
Well, no, I mean, you answered it from a different perspective. And so I received that, and I do appreciate that. Now I'd like to switch gears a little bit. And my question to our panelists is more downstream in terms of understanding that there is a political divide, if you would, in how we think about funding for healthcare. So we just are fresh off the decision with regards to the block grants that the governor and legislators have put into place that could possibly be turned around by the Biden administration. But nevertheless, we still need to make progress with regards to having conversations so we can approach the best solution for Tennesseans. So understanding, taking a step back, what is it going to take with regards to having the common language for both sides to approach a potential solution? Specifically, I want to ask, what does it take? What information do you think the state policymakers will need with regards to a study to compare the costs and health and economic benefits? So do they take that into account with regards to making their decisions with regards to Medicaid expansion? If not, do you think being able to have a study to compare the costs of health and economic benefits would be beneficial as we consider Medicaid expansion? Do you think that that's speaking the language of our legislators? And I'm going to open it. I think Dr. Cahill is probably best prepared as our health economist, but so I'll start with you, Dr. Cahill.
I'm actually going to throw it to Jeff, Mayor Tibbles, because he actually had his hand up.
Okay.
Mayor, I have something from a policymaker's perspective, and then I'm happy to jump in because I do have a response.
Fantastic. Go ahead, Mayor Tibbles. Thank you.
The one thing, as I mentioned before in one of these other meetings, when you look at Medicaid expansion as far as the state level, 3/4 of the legislative body in Nashville is a Republican. And when you look over the years, when ACA, which I don't even like that name, I could go off for hours on it. It's definitely not affordable. It quadrupled the expenses for me for insurance. But when you look at Medicaid expansion actually happening at the state level, I think there's news of it this year. Just talking to representatives, he says, I'm definitely for it. You know, my side of it. But people associated it back in the Haslam days of when he was governor, that it was associated with Obamacare, and it was and boosting and supporting the ACA, which is directly supporting the Democrat. And there was a big wall sitting right there between them, and it was just not going to happen. And the tone I'm hearing from the legislators, the ones I've talked to this year, they seem to be much more open for it.
Fantastic. Thank you. Dr. Cahill.
Yeah, I definitely think that the ACA was significantly hampered by its association with the Obama administration in terms of its implementation in conservative leaning places. But we have seen, just in our northern neighbor, Kentucky, the possibilities for similarly politically orientated states to adopt the ACA and to build on that adopt Medicaid expansion, build on that program. I do think, based on my experiences with the state legislators through the Baker Center, that an economic study about, you know, a cold hard look really, which may not really unveil that Medicaid expansion is what the state ought to do. So, you know, the commission should be prepared for the fact that the answer that you get back from a really cold hard economic look may not be what you are wanting. But I think that if that kind of study were to be commissioned, that would be very beneficial for state legislators to make that sort of determination. Because I do think that state legislators, we are one of the most fiscally responsible states in terms of rankings. State legislators have shown a willingness to make policies and make investments in things like, you know, free college, community college education, which is really not something that's typical of similarly politically oriented states that result in economic growth. So when the economic case is before the legislators, they've shown a willingness to make those choices. I'll give you an example. Outside of the area of health, the gas tax was something that state legislators were very much against, including by Beth Harwell, who was very much against the gas tax. The Boyd Center for Business and Economic Research actually did an extensive study about the economic need for the gas tax, and that's what led, by many accounts, the state legislators to voting to adopt the gas tax, because they were convinced by the economic evidence that it was what was necessary in order to improve the infrastructure of the state and in order to fuel economic growth. And so I do think, I mean, I know that I'm kind of beating a drum here all day long, but I do think that the economic story is something that can be very convincing. And it's really, we don't have a good study for the state of Tennessee on the relative economic benefits and costs of a Medicaid expansion decision. And so I do think that that would be very welcome.
So just a follow-up question, do other states commission such studies? And why do you think that we haven't moved in that direction as a state?
So other states have done assessments after, to my knowledge, other states have done assessments after Medicaid has been implemented to examine the actual cost to the state, because as you probably know, there's a cost sharing element that came into force, I think in 2017, the 10%, to see how much of the state budgets are actually being shared. And so what they found actually in those studies was that most of that cost sharing was actually offset by savings in criminal justice spending, mental health spending, and also their regular Medicaid program spending. And so that actually most states didn't actually have to allocate an additional 10% in order to pay for the Medicaid expansion. A lot of it was, many states experienced actually net neutral, which means they didn't spend anything additional. And some states even resulted in savings. So a net positive as a result of Medicaid expansion. And so most states do it after, in my experience, after they've already implemented. But I think in this case, it would be very beneficial in order to inform the decision-making process. And in addition, the reason why it hasn't been done is because this idea of the connection between health as a driver of wealth, of economic growth, really is something that economists are just now starting to consider. And to be quite frank, it is also a difficult problem to analyze. There are a lot of confounding factors. There's reverse causality that make it very difficult. And so it would take quite a bit of attention and interest from an economist's point of view in order to do the study justice. And so that's probably one of the reasons why it hasn't been done, because it's really not something easy to do. So it is possible. It's just not something that somebody would just kind of whip up as, you know, a policy brief or something like that.
Right. I know that this conversation has been floating around for a few years. Ms. Beard, I'm wondering if we were able to move in that direction. How do you think the provider perspective, provider voice would be able to contribute to this process?
Sure. I mean, I believe, you know, we can definitely provide, you know, data because, you know, the data that's tracked on uninsured patients is different than data that's tracked through hospital data or through billing, because there are no billing forms per se for uninsured patients. And so trying to capture that data, I think, would be a little bit challenging and maybe part of the problem that has caused the state not to be able to have a full breadth of what this situation is. And so I think from the provider standpoint, giving our data that we have from our area of the spectrum, I think would be beneficial.
And thank you. And then Dr. Myers, I'm wondering if commissioning such a study is an opportunity to move in the direction of having a common language for individuals on both sides of the aisle to approach this conversation. What are your thoughts regarding that?
Well, I'm glad you asked the question, not just to me, but the question that started this discussion, because the genesis of this session was the fact that we weren't successful with Medicaid expansion and we needed to change the conversation, to your point about language, and we needed to change who we were talking with. So I think the fact that we would segue to talking about an economic argument rather than kind of abstract ideas about health as a right and those sort of things, I think we'll have some salience with our current legislators and governors. And then I have a few things that I am hopeful that maybe we have a little impetus, which seems odd to be hopeful right now, but I'm hoping that we'll see a dial back of the political posturing. Unfortunately, during the hearings on the waiver, there was a lot of just outright wrong statements. And I'm hoping that maybe we'll take a pause and start to say really what's best for our state, and do away with some of this misinformation. So to bring information to the table, I think will help to mitigate that. I want to also make sure that people know that the expansion is not precluded by the waiver. You can still have expansion, and don't forget, it's a long road, but President Biden's public option plan would take us as a non-expansion state and expand Medicaid. And then we have the third thing, which is the shared savings. Now, it's going to take a long time to accumulate sufficient shared savings to do anything, but there's this prospect of maybe being able to fund some expansion, either of benefits or eligibility, through the shared savings. So I think that if we want to engage legislators and other key stakeholders, county mayors, local mayors, business people, that we're more likely to engage if we have economic arguments and not other arguments. And we have to become versed as advocates in how to easily translate the information we heard from Dr. Cahill and from Mayor Tibbles about the health wealth connection. Their two presentations were perfectly complementary.
Thank you. Now I would like to turn our attention to questions that I have received in the chat. And the first one is for Mayor Tibbles. Several years ago, the state passed a law to help hospitals in distress. This help comes out of the TennCare office. What specific help have you received from the state through the TennCare program?
None, put it bluntly. And we were in contact with TennCare. We were in contact with everything to do with the national offices related to hospitals. During the process back 8 years ago, 10 years ago, it was all the time we were in contact in Nashville. And I don't recall of any funding that we were ever given to assist us prevent the hospital from closing.
And elaborate on any reason or justification that you offered on why you weren't.
Well, let me get over this image right here. We were not given any kind of reasoning for anything being turned down at all.
Okay.
Now, if you talk about the CARES Act funding, is that what you're talking about now?
Well, we haven't talked about COVID, and so I think this would be a really good segue to COVID. So talk your experience with that process.
With the COVID funding, I mean, it's been wonderful across the state. I don't know how we're ever going to pay federal government's going to pay this debt off. I think we're getting ready for a deep recession, which is not going to make this situation any better. The people who are going to get hit the hardest are the already poor, and they're going to be poor very quickly. It's going to be a problem. But if you look at COVID, I do not understand. As far as the county government level, I think we've been given, and of course you had to justify every penny that goes out the door, but we've $330,000. We just finished at expenditures on helping out with payroll or any kind of PPEs we need, or as far as that's concerned, the state has been wonderful helping us with that, as well as TEMA and FEMA. The one thing I don't understand, and I still, and the Congressman Fleshman's office is still trying to get an answer why the local hospital was turned down for CARES Act funding. They received it on the first go around. And it was a lifesaver for them because they're still handling COVID patients. They're still having to do all the preventive measures when they come in, and they're not being reimbursed for any of those.
Okay. Thank you for that. I would like to go ahead and open it up to the audience for questions. I'm looking for the raised hand icon, so if someone can help me out with that, that would be fantastic. But does anyone have a question? In lieu of the raised hand, I invite you to come off mute if you do have a question for our panelists.
Hi, this is Kanika. Oh, sorry, was someone else talking?
Please go ahead, Kanika.
Okay, I just wanted to follow up on my question about the implications for the state's ability to expand Medicaid. As Dr. Myers mentioned, there's a lot of uncertainty in the block grant waiver, and I think this is one of those examples. From our review of it and input that we've gotten from other experts is there's a possibility that the state would not be able to expand Medicaid. While the block grant doesn't address Medicaid expansion explicitly, the waiver does set aggregate funding caps for each year based on historical spending levels in 2019. And there doesn't seem to be room to adjust the aggregate caps upward to accommodate an entirely new eligibility group. And so that's where the uncertainty lies. The only population-related adjustment to the aggregate caps is the enrollment risk corridor. And the expansion population does not appear to be one of the 5 groups for purposes of the enrollment risk corridor because they did not exist in state fiscal year 2019. And there's therefore no baseline enrollment number against which to apply the 1% test that Dr. Myers mentioned. There's also no projected per member per month payment rate for them for purposes of calculating the amount of the increase in the cap in the table that's set forth in the waiver. And so that's where the uncertainty lies. And I just wanted to raise that question.
Okay, so so I'm going to ask Carol or Dr. Myers if you will start by responding to that analysis and the question.
And I'll answer what I know, and then I'm gonna ask if there's anyone else that's participating that knows more. I think Kanika raises some very good questions. However, I did read one analysis that said they did not think that the TennCare 3 waiver precluded expansion because it would be outside of those 5 categories. So it would be done separately, but I could find no affirmation or support for that idea, but someone put that idea forward. And then again, I also ask in the follow-on to Kanika's question, what happens if we do see the public option pass, which is going to be several years down the road by my estimation. So I don't know. I don't know if there's someone else among us on this webinar that has a better answer or a better points of discussion to respond to Kanika.
I'm going to follow up and ask if anyone on the call has a perspective that would be helpful.
And I'm going to qualify, Kanika, the majority of my knowledge came from the Sycamore Institute and then reading just some news reports, etc. You know, this is 8 days old. Yeah.
Yeah. And we discussed this week about being able to prepare an uncertainty. So I appreciate this happening in real time. Please go ahead, Kanika.
Sorry, I was just going to say, I definitely agree that it's unknown and there's a lot of uncertainty, and I didn't really expect anyone to know the answer, but I just wanted to put it out there in case there was a different line of thinking behind that uncertainty.
All right, thank you. Rich Hennigan.
Thank you. I just had a brief comment on that discussion, and then I have a question, which my comment is that there's no harm in assuming that we can go ahead and talk to our legislators about expanding, even with the block grant approved. It seems like, I mean, Sycamore was very unambiguous in their statement that it was not precluded, but I guess not being precluded and somehow fitting well with the waiver are two different things. But anyway, my question is this about the drugs and the drug formulary. I'm a mostly retired nurse practitioner, and I know that Medicaid has always had drugs that were available and drugs that you had to request if you wanted to get them approved. And so this notion that it wasn't a closed formulary was a surprise to me. And so I'm wondering if anybody can clarify that issue. Does anybody know the ins and outs of TennCare to know what were they doing before and how has this changed it? Thanks.
Rich, I am a fool to try to answer a question from you when I know you know this much more than I do. But my understanding when I was prescribing that TennCare had preferred drug list and we had to get prior authorization for things, this is actually going to be a formulary that that's, which to me is a step stronger as far as what has to be done. But I have not seen anything in what I've been able to read other than they think it's going to be a fairly contentious process to develop that formulary because it has to be done with some public input and other review. So maybe someone else can speak to that, but I think there's a change in how strong is the recommendation from preferred to a formulary, which to me is more restrictive, more absolute.
With all of the promises that various legislators have made about not cutting reimbursements to providers and not cutting numbers and not cutting this and not cutting that, the drug formulary would seem to be the one area that's quite ripe for people to try to figure out how to save money.
Well, I think it is, but I also think it's the area where, because of prescription drug costs, there's a lot of attention. And I don't know that that's totally a bad thing, but I think the concerns from the advocate community, particularly about vulnerable patients and what could happen with the formulary, I think that's one of the most acute concerns now that we have the guardrails about number of eligible people and benefits, that this is where a lot of attention should be turned. And what is the absolute meaning for people who are living with catastrophic chronic diseases like multiple sclerosis, et cetera. So my advice to this community would be, we need to be actively engaged in the development of the formularies.
And now we can add COVID to that list because of the unknowns in the long-term prognosis. Carol, I was wondering if you could answer the next question or take a shot at it. When is the Medicaid block grant waiver due to take effect, and what is the likelihood that court challenges will delay implementation of the waiver? Is it possible for you to elaborate on the provisions that make it more difficult for the Biden administration to cancel the waiver?
Okay, so 3 questions. The first, I don't know the answer to the first question, but I would look to the fact that our current waiver expires June 30th. But I don't know how you can get everything that has to be done in these chaotic times done by then. So I don't know the answer to the first question. The third question was about legal challenges. What was the middle question?
The middle question is, what is the likelihood that court challenges will delay implementation of the waiver?
And again, I'm going to ask for help for a friend. I think oftentimes what's going to happen is the legal challenges will come because it's a federal program. And if people's rights have been violated, they get redress through the federal courts. So to me, that means, in a simple way, and I'm asking for help, is that we might have to go through implementation and have an actual case where rights have been allegedly impaired. So I don't know how much can be done in advance, but with Medicaid work requirements, we did see some stoppage why court cases were going on. I am not a lawyer, and neither is Mayor Tibble, so I kept trying to make him one. So any help from anyone in the audience? We've got a really esteemed audience here.
May I chime in?
Thank you. I was
We have a
hoping.
lawyer. Yay.
I am a lawyer. Doesn't necessarily mean I know the answers to all of these questions, but on the first question about the effective date, I just want to point out that the official effective date of the waiver was January 8th, the date of approval. That allows the state to basically, on a retroactive basis, implement some things. The state does have until, I guess, the end of their current TennCare 2 waiver period to get their processes in place in order to implement this waiver, but the official effective date was the date of approval. On the second question about the possibility of litigation to halt this, I agree, Dr. Myers, that the waiver would need to be implemented, and there would need to be some harm that could be shown in order to support a cause of action. And with the work requirement waivers that have been the subject of litigation, those were in states where they had been implemented, not just approved. And so specifically for work requirements, they could show this loss of coverage as a result of the work reporting requirements. So until you have that evidence of some kind of loss, I don't think that we would be able to successfully mount a challenge. And I think the third part of that question was about the provisions that make it harder for the Biden administration to unwind. I'm putting a link to a blog in the chat that lays out those procedures. And essentially it requires these notice periods. And if you do the math of what's laid out in the procedures, it's a 15-month process. So the first is no sooner than 9 months after the date that CMS notifies the states of the state of its intention to invoke the option, may there be any sort of withdrawal. And then there's another period for the state to request a hearing, and for the state to submit briefing outlining the basis for disagreeing with CMS's withdrawal, et cetera, et cetera. So when you add up all of those different timeframes, I think you may arrive at about 15 months.
Thank you, Kanika. That's very helpful. And I think there actually was a fourth element to the question, is what provisions do we think from the TennCare 3 waiver would be most likely the target of legal action? And I don't know the answer to that. I know that there's a strong assurance from CMS that they've looked at all the legal challenges. Well, they said that with the work requirements also. And basically what you do is you go back to look to the 1965 legislation as to the two primary purposes for Medicaid. And that's where the objections to work requirements have originated. But again, Kanika, I know just enough to be dangerous, and you know enough to be right.
Attorney Young, thank you. Thank you so much for being an honorary panelist today.
Yeah.
Yeah, sorry. I think I agree. You look at the purposes of the Medicaid Act in terms of providing access to health insurance to people, but one of the key things that I think is likely to be challenged is the closed drug formulary. And we know that the pharmaceutical industry is big and powerful, and they put out a statement against TennCare's block grant waiver. So that's one party that I think may have an interest in pursuing legal action because of that closed drug formulary.
Thank you.
Thank you. Thank you, Attorney Young. And thank you to all of our panelists today for sharing your expertise, your perspectives. What we hope to get out of this conversation was a better understanding of the value of healthcare coverage at the individual, population, and societal levels. We wanted to discuss the prospects for extending healthcare coverage to uninsured Tennesseans from a federal and a state perspective. And that includes, in my opinion, considering a study to be commissioned about the economic impacts of public health and healthcare. And also lastly, to describe alternatives to federal programs for extending healthcare coverage from a local rural perspective. And we were able to touch on that in Ms. Beard's presentation. This conversation is going to be continued. I know that there are questions in the chat that we weren't able to get to today, but I do have a commitment from the organizers to jot those questions down and try to send those out and get those answers. With regards to if the presentations will be available, I believe Dr. Cahill has already shared her presentation, so we will circle back around with the presenters to see if that's possible. I want to thank all of you all for joining me today, and it was good to see new and old faces and names. I'm going to go ahead and turn it over back to the Tennessee Healthcare Campaign. I'm going to start with Judy. I'm going to turn it over to you and Randall. Thank you.
Thanks to everyone for a great discussion. As we learned from our panel, Tennessee is near the bottom in terms of health, and we're all in this together, and the poverty and lack of insurance of our neighbors affects the health of all of us. So 1 in 10 Tennesseans are uninsured in the midst of the COVID pandemic. We have rural hospitals closing their doors, leaving big gaps in urgent services. Black and brown communities struggle with losses as a long, ugly history of racism causes persistent health disparities. We are seeing the results of a decade of health policy failure. Tennessee Healthcare Campaign is fueled by a determination that we can and must do better. Here are 3 things that you can do. First of all, I invite you to go to our website and sign up for our action alerts. We'll let you know about important issues in the state and national health policy and give you an easy way to contact your elected representatives. Second, we are very grateful to those who are able to support us financially. If that $600 stimulus check is burning a hole in your pocket, if you enjoyed this free webinar and want to see more, please help us out as you are able. And finally, we need your expertise and we need your stories. If you or your family is impacted by Tennessee's failure to insure low-income workers, please contact us. We want to make your voice heard. We need your help to make this a year of positive change. We need a campaign to fight for equitable, quality healthcare for all Tennesseans. And we need to raise up the voices of people like you across the state. So please join us.
Thank you. And on that note, we invite you to please enjoy the rest of your day and reflection on Monday for Martin Luther King Jr.'s Day and the inauguration. Please stay safe, and we look forward to continued dialogue and reflection as we continue the work. Have a good one, everyone.